Okay, so we're going to roll into colchicine versus non-steroidal anti-inflammatories for an acute gout attack. We'll probably focus a bit more on the colchicine side of things. I know Ollie did his presentation last week, last 2 weeks ago, whenever it was, on naproxen. So that's a good one to review if you wanted to consider those factors. But we will compare both of them today, essentially for an acute gout attack. So just quickly, agenda, I'll run through intro to gout, comparison of colchicine obviously versus NSAID for that in terms of mechanism of action, efficacy, indications, contraindications, dosage, side effects, interactions, how to differentiate for different patients, and a bit of a case study application. And then we will just briefly touch on lifelong urate lowering therapy. So something like an allopurinol and how we can be involved with that as well in terms of testing and then some regulations and guidelines. So as a way of intro, gout approximately affects 1.6% of Australian adults, more prevalent in males, probably seeing more of a rise in it due to lifestyle factors. So yeah, things like your diet, obesity, aging population. We know that's related to alcohol consumption, and it also has a large genetic factor to it as well. Obviously, we can be quite important in the gout management, being often the first healthcare professional to assess. Has anyone, as like a bit of a show of hands, seen anyone or treated anyone with an acute gout attack before or recently? Rubes, did you do it since you had your endorsement, or was that pre-endorsement?
Pre-endorsement. And then I think they end up seeing Steph or Ollie. They prescribe something for them. Or they've gone to their GP. Yeah.
And what about you, Chris? So was that pre or post endorsement?
It was also pre-endorsement, so I ended up referring them to their GP. I think they got some anti-inflammatories. Fine.
Yeah, cool. I want to run through just quickly, just a brief overview of what gout is. So if I can get this to work. Is that switched over to YouTube? So just a very brief video on what gout is.
Gout is an inflammatory disease in which monosodium urate crystals deposit into a joint, making it red, hot, tender, and swollen within hours. When this happens, it's called a gouty attack. The underlying cause of gout is hyperuricemia, too much uric acid in the blood, which results in the formation of sharp, needle-like crystals in areas with slow blood flow, like the joints and the kidney tubules. Over time, repeated gouty attacks can cause destruction of the joint tissue, which results in arthritis. To understand where the uric acid comes from, let's start with purines, which together with pyrimidines are nature's most common nitrogen-containing heterocycles. A heterocycle is a molecular ring with different types of atoms. Purines, as well as pyrimidines, are key components of nucleic acids, like DNA and RNA. And when cells, along with the nucleic acid in those cells, are broken down throughout the body, those purines are converted into uric acid, a molecule that can then be filtered out of the blood and excreted in the urine. Uric acid has limited solubility in body fluids, though. Hyperuricemia happens when levels of uric acid exceed the rate of its solubility, which is about 6.8 milligrams per deciliter. At a physiologic pH of about 7.4, uric acid loses a proton and becomes a urate ion, which then binds sodium and forms monosodium urate crystals. These crystals can form as a result of increased consumption of purines, like from consuming purine-rich food like shellfish, anchovies, red meat, or organ meat. Also, though, they can result from increased production of purines. For example, high fructose corn syrup containing beverages could contribute to the formation of uric acid by increasing purine synthesis. Another way crystals could form is from decreased clearance of uric acid, which can result from dehydration from not drinking enough water or consumption of alcoholic beverages, both allowing uric acid to precipitate out. Regularly eating these kinds of foods can also lead to obesity and diabetes, both of which are risk factors for gout. Hyperuricemia can also develop as a result of chemotherapy or radiation treatment, since cells die at a faster than normal rate. Also, some individuals have a genetic predisposition to overproduction of uric acid, while others with chronic kidney disease may be unable to excrete the uric acid. Finally, there are some medications like thiazide diuretics and aspirin, which can also increase the levels of uric acid and therefore the risk of gout. Now, gout.
So just a bit of an overview of gout to start off with. Now, our case study presentation is going to be a 52-year-old male presenting with, severe pain in the first MPJ. He's had an attack of gout previously, 6 months before. In terms of relevant factors, overweight, has hypertension, is taking an ACE inhibitor for that. His serum urate levels are elevated. His eGFR also is quite normal. Current management is he's taken a non-steroidal anti-inflammatory in the past for his gout attack, but he's previously reported that he got a bit of an upset stomach when he'd previously taken an anti-inflammatory. Just a brief bit of information about colchicine, Schedule 4 anti-gout medication, formulations of 500 microgram tablets. In terms of the mechanism of action of the two different medications, I'm just going to flick over to another video quickly that'll just briefly explain the difference between a colchicine versus a non-steroidal. Again, a good one to review would be Ollie's presentation on naproxen to have a look at the actual mechanism of action of an NSAID, but we'll flick over to this video.
Okay, let's move on to the treatment of acute gout. The first line treatment is a non-steroidal anti-inflammatory drug, such as indomethacin or ibuprofen. These medications work by reversible inhibition of cyclooxygenase, which is an enzyme responsible for the production of prostaglandins that cause inflammation. It's important to note that aspirin and other salicylates should be avoided in gout because they're weak acids. Therefore, they can compete with uric acid for secretion in the proximal tubules. On the other hand,
So just briefly, the NSAID obviously is treating the inflammatory side of things and can act as obviously an anti-inflammatory, but also as a pain modulator as well to reduce the pain associated with it.
Corticoids such as methylprednisolone and prednisone work by inhibiting phospholipase A2, which is another enzyme responsible for the production of prostaglandins. Moreover, these medications can be administered orally, parenterally, or by intra-articular administration.
Obviously for us, the glucocorticoids are less relevant. In this case, we're more focusing on NSAID and colchicine.
The last medication in this group is colchicine, which works by binding tubulin and inhibiting microtubule polymerization, thereby inhibiting neutrophil migration in joints and reducing inflammation. Other indications for colchicine include prophylaxis of gout attacks and familial Mediterranean fever, which is
So the colchicine side of things is more treating the production of the white blood cells that are producing or leading to the inflammation. So rather than just the inflammatory pathway, specifically they're targeting those white blood cells. So to start off with, comparing the efficacy of the two, colchicine to start off with is going to be most effective when started within 12 to 24 hours of symptom onset. And in the literature, it says there's approximately 75% efficacy rate when used correctly. Its onset of action can be a little bit slower, typically that 12 to 24 hours, with ideally complete resolution around that 24 to 72 hours. There's a good amount of evidence, and what the evidence is pointing to is lower dose being just as good as a higher dose with fewer side effects. So like a lot of our prescribing sort of thoughts is less is more, and it's the same in this case. NSAID usually effective when started within 48 hours, so can be used like a little bit later on in that cycle. And evidence kind of says anywhere from like 60 to 90% efficacy, so probably pretty similar to that 75% as colchicine. Onset of action is a little bit faster, typically that 1 to 3 hours for pain relief, and then complete resolution maybe being that little bit longer, that more 5 to 8 days. So they've used naproxen in studies before. Obviously, when we're talking about a non-steroidal anti-inflammatory, it's pretty broad because we know there's a fair few different ones. In most of the literature and certainly on Australian Medicine's Handbook, they refer to naproxen as being the option of choice. So yeah, in comparison, probably pretty similar in terms of efficacy. NSAID is probably just that little bit quicker, whereas colchicine is probably providing that more complete inflammation resolution. And then there's also an argument to state that combination of both of them might be superior if there's no reason why or no contraindications or drug interactions that might be at play. They found that using both in combination can be quite good. Did you have a question, Chris? I just saw you went off mute.
Yeah. Have you been like going across slides? Because
Yeah,
well,
you can't do it.
nah, I don't know if it's about anyone else's, but it's stuck on mechanism of action for me. Is that just me or is that everyone else? There we go. Now it's working.
Yeah, try and switch between like presenter view versus not.
Yeah, okay.
If I do that, does that change it at all? Not really. If I'm
Yeah, that changed it. Yeah, that's changed the slide. Yeah, it was just stuck on mechanism of action. I was like, I'm pretty sure I heard him click a button.
cool, no troubles. What slide is it on at the moment? Sorry, just for reference. Colchicine indications.
Yeah, colchicine indication.
Okay, cool. Nice. So indications for colchicine to start off with. Depending on where you read, some of them say that like an NSAID is first line, some of them say colchicine is first line. So in this case, I think, yeah, for our patient in question, the first line treatment in our case would be colchicine. We'll go into the reasons why as we get on, but essentially it's preferred in cardiovascular disease, like our patient potentially does have, if they've got mild to moderate renal disease, history of NSAID intolerance, which in our case, the particular patient does, if they're on anticoagulation therapy, and it's also used probably outside of our scope, but in prophylaxis of urate lowering initiation. So if someone's starting allopurinol, oftentimes they'll use it prophylactically to reduce the chance of any flare. Contraindications on the flip side for colchicine, severe renal impairment and hepatic impairment, and obviously combination of those two things. Concurrent use of the common drugs that someone will be taking if they're going through chemotherapy, which those drugs that are listed, they just reduce like the interaction between some of the chemotherapy medications that people take concurrently. So yeah, if someone's doing chemotherapy, probably one that we'd want to find some more information about and potentially refer on to their GP if needed. Pregnancy is contraindicated. And then if someone has, disorders of the blood, bone marrow, and lymphatic tissue. In this case, for the more uncomplicated conditions, an NSAID might be indicated. It's preferred in those younger patients without comorbidities, so without cardiovascular troubles, for example. It's probably a bit more indicated when we're looking for that rapid pain relief. So if someone comes in with that really painful gouty attack, we know that a non-steroidal anti-inflammatory is going to act a bit more efficiently. Obviously, if colchicine's contraindicated, like any of those reasons that we chatted about just before, and then obviously if they've had a good result by using an NSAID in the past, there can be another indication to use that. Contraindications being any GI sort of issues, peptic ulcers or GI bleeding, moderate to severe renal impairment, heart failure, heart disease. Also, if they're taking current anticoagulation therapy, aspirin, these sorts of things. Pregnancy in the 3rd trimester, and then obviously that triple whammy effect. So if they're already taking like an ACE inhibitor, and a diuretic, we want to avoid that as well. In terms of the dosage of the two of them, colchicine. Yeah, you're on mute, Kuso. You're on mute, Kuso.
We're still stuck on colchicine indication
Oh, that's all right.
slide.
I'm gonna scrap the presenter view and just go with. So we're good with dosage administration.
Yeah.
So yeah, dosage for colchicine within our scope, it's not recommended that we're doing it for longer than that 24-hour period. If there's ongoing troubles, then we're referring off to GP. But the low dose regimen is 1 milligram of loading initially, and then 1 milligram or 500 micrograms an hour after. We're clearly reducing dosage in elderly and people with renal impairment. That prophylactic dose, like we we're talking about before, probably less relevant to us, but the prophylactic dose is that 500 micrograms daily or bi-daily, depending on the client. It's not too dependent on whether they take it with food or not. The NSAID dosing option, if we're taking naproxen as an example, the recommended dosage is at 500 milligrams bi-daily for the 3 to 5 days, and then as soon as possible try and taper that off as well. Obviously, taking it with food to reduce the GI effects is super helpful as well. And again, the shorter the duration that we can prescribe medication for, the better. In terms of some of the common side effects that we might see for colchicine, the most common one is diarrhea for these patients. Also, nausea and vomiting can be seen as well. And then, yeah, certainly some of these more severe but less common ones are something to think about as well. Clearly, some of the more long-term options are something that we need to be aware of. But because we're not, hopefully not treating them, I'll say long-term medication, it's going to be part with the GP and communicating with them. But still, yeah, certainly something to consider. And as I've spoken about, some of the precautions being renal and hepatic impairment. An interesting one that I found was, yeah, grapefruit juice can increase colchicine amount in the bloodstream. So good to ask our patients about that as well. Obviously, elderly patients can we can reduce that dosage just slightly as well. And yeah, it's really important that we know to monitor for those early signs of toxicity. So always good to make sure that we are following up with these clients within that 24 to 48 hours, whether that's rebooking them to see how they're traveling or following up with a phone call. Again, we'll go through some of the NSAID effects and precautions, but the most common ones being the GI bleeding and ulceration and people getting upset stomach from that. And like I've said, using the lowest effective dose where possible as well. So as a bit of like a comparison, obviously, like, yeah, the colchicine can be a little bit worse from the GI tolerability from the diarrhea kind of point of view, versus NSAID can be a bit more, obviously, as we know, it can cause GI bleeding and ulceration. So just good to find out if they've had any of those considerations previously. In terms of some of the most common interactions, so colchicine being some of those, those chemotherapy type drugs, and as we mentioned, the grapefruit consideration as well. so statins can increase risk of myopathy, same as fibrates, and vitamin 12 can sometimes decrease the absorption of it. Not a huge consideration, but just something to take note of as well. And then with an NSAID, we know that obviously some of these ACE inhibitors and diuretics, we want to stay away from that. Some of the anticoagulants can increase risk of bleeding, obviously increased chance of GI bleeding, and SSIRs, methotrexate and lithium as well as considerations. So in terms of like clinical decision making and the process that we obviously need to go through, it's like with any other medication. Obviously, we're reviewing the complete list of medication before prescribing anything, checking for any of those high risk interactions, considering if you need to adjust the dosage amounts. Obviously, we're always consulting with the GP and the pharmacist if unsure and documenting anything. On the APRA guidelines for us as endorsed podiatrists as well regarding contacting the GP. I mean, we should be doing it anyway, but it's a requirement of us if we're prescribing colchicine to let the GP know via letter that that's what we're doing. So if we're looking at the patient selection factors, so favoring colchicine is, yeah, if someone, so this is kind of the list that would go through if we had someone come in with suspected gout. This is the kind of things that we'd be considering whether we help them by prescribing anti-inflammatory or colchicine. So for the favoring colchicine side of things, obviously if they've got, yeah, cardiovascular disease or risk factors in this sense, we'd be favoring colchicine. If they're on anticoagulation therapy like warfarin and these type of medications, yeah, young in age and early presentation. Obviously the need for prophylaxis, again, not super relevant to us, but good to know. If they've used a non-steroidal anti-inflammatory in the past and they've had intolerance to it, and there's some evidence to suggest that in those more severe cases where there's presence of those like large tophi that you can see, that it may be more favorable in that case, as opposed to, yeah, an NSAID. As we've chatted about, there's a bit more of that immediate pain relief. So if someone's just in quite a bit of pain and wanting a quicker solution, the NSAID is going to be a bit quicker acting. If it's an isolated attack without any of those other comorbidities that we spoke about, if there's any of those colchicine contraindications that we went through, obviously if they've had a good response to an anti-inflammatory in the past, yeah, if they've been able to tolerate it from a GI perspective previously, and then obviously looking at their renal and hepatic function if that's normal as well. We'll come back to the case study in a moment and discuss the use of the short-term outcomes and what we're doing in that sense. But just out of interest, and I think it's something we should know about, is the long-term management. So the urate lowering therapy. Probably the most common one that we'd come across, at least in Australia, is the allopurinol. The indications for someone that might need lifelong urate lowering therapy would be recurrent attacks. So if they're having more than 2 per year, presence of those larger tophi that we might be able to see. If they're developing that like chronic gouty arthritis, because we know that can lead to joint damage, which can show up on X-ray and imaging, would be the main kind of factors when we're considering that. In terms of our role in that, obviously identification of the appropriate candidates to start off with. So if we've got someone that's coming in with some of those factors that we went through, certainly having that conversation with them, and then obviously leading that to referral to GP or rheumatologist. Yeah, just educating them about the urate lowering therapy expectations, reinforcing the importance of adhering to it, and probably talking through some of those implications from a long-term perspective if they're not adhering to it. And then we're also seeing a lot of these patients and a lot of these clients regularly, so monitoring for more lower limb manifestations, because we know yeah, joint destruction, and pains associated with that can lead to other things as well. So the testing and the referral pathway would sort of go through initial podiatric assessment, where we're going through our normal points. If we do have point of care ultrasound, I don't know, have you guys, particularly Chris, have you used the point of care ultrasound before on one of these joints?
I've definitely used it on like a first MPJ or something, but yeah, not specifically for gout.
Yeah, yeah. So yeah, looking for that like a double contour sign, and probably like anything, the more that we're using it and looking at it, we'd be able to identify it more so. And I think probably differentiating it from some of those more severe other crystal arthropathies as well can be important, like your septic arthritis, these type things. And then in terms of the tests, and again, most of these are getting done through the GP, but they're going to be looking at serum urate levels via blood test, renal function, liver function, and often getting like a full blood count. And then sometimes for those more severe kind of cases, if we want that absolute confirmation, the GP might refer off to a specialist, or might do it themselves, joint aspiration, just to be able to test those levels specifically.
I was going to say, sorry to interrupt. I had a patient 2 weeks ago, I'm seeing this afternoon, and like that typical chronic gout, first MTPJ, but he's not on any like long-term medication. But his main concern is the pain in the joint. Sent him for scans, and then the radiologist rang me, and it was pretty much like all that stuff. He's like, you need to get it aspirated to check the actual joint, make sure there's no infection. Yeah, because it was just he's like, there's so much like gout in there and crystals in there that needs to be checked further. But yeah, so this has been good to.
Yeah. Have you seen him before?
No, I saw him for like as an initial 2 weeks ago, and then he's in again this afternoon.
Yeah. And when you saw him for the initial, was it for the same presentation and you sent him off for scans?
Yeah, because he was just like, it's so painful. And I've got this big lump, like he's got another lump that's just come in the last couple of weeks on top of his joint now that he was a bit concerned about. And that's what the radiologist was like, we need to check that because it's now like popping up outside of the joint kind of thing. But
Yeah, interesting. And was that like his first attack that he's had? Has he had anything like that before?
no, he's had a couple over the years, but he's like, no, I'm not, I just take the medication when it happens. And I'm like, I was kind of trying to push him back to the doctor to go on like a long term. So now I'm like, now I've got the scans, you're going back to your doctor.
Yeah, and definitely you can kind of use that to explain like that joint destruction type
Yeah.
things, and yeah, the effects of not treating it, how it can have that long-term kind of effect for sure. Yeah, it's interesting though. Was it one of those ones, could you see like the gouty toe fire?
A little bit, yeah. I was just like, when I first saw the toe, I was like, there's a lot going on here.
Yeah, nice. So yeah, some of these referral indications, particularly for us, first MPJ involvement, multiple attacks, those elevated serum urate levels, comorbidities, presence of tophi, kind of that's that exact patient that you've just described, Rubes. And then yeah, just our normal documentation process, history of the client, if we do have any test results, findings, medications, and then our proposed management plan as well. So like with anything, when we're prescribing medication, just making sure we're documenting it appropriately. So back to our case study. So yeah, we selected management with colchicine in this particular patient due to a couple of things. Didn't go with an NSAID because of the hypertension and the medication he's taking for that. Like we said, he's previously taken anti-inflammatory and had the stomach troubles. And he's also got that normal renal function permitting the use of colchicine. So yeah, in this case, prescribed that low dose of colchicine, 1 milligram dose initially, then 500 micrograms an hour after. Other things that we know can be helpful as well, like with most musculoskeletal conditions, like resting the joint, making sure that we're trying to protect it and offload it. there's a little bit of evidence to say that just icing can help from a pain response point of view as well. And yeah, like I said, following up within that 24 to 48 hours to assess how they've gone and the response, making sure that we're keeping the GP filled in as well. So writing a letter to them and following up with that. In this case, because it had been a gentleman that had suffered from it before, had some of those comorbidities associated with it, the GP initiated allopurinol 100 milligrams daily after this acute phase for that urate lowering therapy, and included the colchicine 500 milligrams daily for flare prophylaxis as well. And then, just regular communication, because it was a patient that we saw regularly for general care as well. So just following up with the GP afterwards, just giving them an update on how that particular patient was going. Just briefly to finish off, just some of the guidelines and protocols that are outlined. Australian Rheumatology Association on the acute management shows kind of what we've gone through. Colchicine NSAID can be equally effective first-line options. Obviously, it's patient-specific. Lower dose, both with colchicine and the anti-inflammatory where possible as well. TGA, same sort of thing. Consider comorbidities, particularly cardiovascular and renal. Low dose NSAID, low dose colchicine. And then lastly, the Podiatry Board of Australia. Same thing. We have obviously the NSAIDs and the colchicine within our scope of practice, clearly documenting, obviously recognising our prescribing limitations, and that mandatory adverse event reporting, as well as the mandatory reporting to GPs as we're seeing someone and starting them on that therapy as well. Does anyone have any questions off the back of that?
How did you did they, with their liver function, did they know that, or did you bring the GP up when you were treating them?
For that case in particular, good question. I think we did call the GP up, and they'd had some previous testing, just because of some of the comorbidities that he had, and the GP was reasonably efficient with getting everything tested. We'd called them up and had a look. Actually, no, it's coming back to me. We did, we saw the patient at one of the medical centers that we work at. So I've got access to tests and those sorts of things. So I was able to look it up at the time, which is handy.
That is handy, because I know like a big thing like for doing the case studies, like I think I did a gout one on colchicine, and the big thing was like, it's like if you can assess like what actually is the liver function, or what actually is the GFR, like the kidney function, that kind of thing. Like they love it if you can actually have that data.
Yeah, for sure. And obviously it can be hard to prescribe without those things, but obviously if we're asking someone about their medical history, comorbidities, all those sorts of things, and they're like a young, healthy person with no real comorbidities, we can reasonably confidently prescribe things. Obviously, if it's someone that's a bit more elderly or with a history of some of those comorbidities, that's when you'd be obviously doing some more investigation before prescribing some of these things. And it's also where it can be super helpful if they've taken something in the past, like if they've taken anti-inflammatory in the past and haven't had any troubles with it, even if it wasn't for gout, if it was for a different musculoskeletal condition that they've taken an anti-inflammatory before and not had any troubles, then it can give some good information with that. Any other questions, thoughts, comments? Love
The
it.
patient tolerate the colchicine well? Like they were fine, like you didn't have to navigate any of those like side effects or anything, or?
They were okay in that case. And I've seen a patient as well since endorsement that we treated with an anti-inflammatory. In that case, it was a reasonably young, like 40-year-old, who, was pretty fit and healthy, didn't really have any comorbidities, had taken anti-inflammatories in the past for musculoskeletal conditions without any troubles. I think he'd taken one in the last 6 months or so for something else that he had going on and didn't have any problems with it. So I think in that case, the one that he'd taken had been Celebrex, like he'd taken that previously and didn't have any troubles. So we just prescribed Celebrex again in that case because we knew it worked for him. He'd taken it before, and he took that, and I followed up with him. It was about 36 hours afterwards, and he had some good relief already from that.
Nice. It was a ripper presentation, Nelson. Just it was good.
Thank you. Happy days. Well, all good. Did you have anything to follow up with, Chris, to finish off?
No, that was the from Steph was just the fact that you had an excellent presentation to roll out, which we have, which was pretty good. Probably actually one other comment. It was interesting that aspirin's a risk factor for it, because I was just thinking that's like something that so many of our patients are on like prophylactically for like strokes, like myocardial infarction, that kind of thing.
Yeah, I think it's just like that anticoagulation effect of it. And yeah, to be honest with you, probably something just need to look into a little bit more of. But it is interesting how often aspirin pops up as something that's a bit of a risk factor for other medications.
Considering it's so widely prescribed.
Absolutely.
Alright, guys. Anything else for Nelson? Or we might wrap it up.